Hello, everyone, and thank you for taking the time out today to invest in the health and well being of transgender and non binary communities. I am excited to share with you how every health provider can create transgender and non binary inclusive clinics. Today's training is geared toward health providers of all disciplines and in all settings. So, whether you are joining from a medical clinic, a social services organization, or a holistic health center, today's information will be applicable to the services you provide to your patients and your clients. Stick around to learn 5 tips on how you can create trans and non binary inclusive health environments. And stick around until the end to hear about a special announcement and offer for everyone who is registered for today's training. So I'm just going to go ahead and share my screen here. If you can see the screen and you can see where it says how every health provider can create transgender, non-binary inclusive clinics, go ahead and put in the chat a hashtag live if you're catching it live right now, or if you're catching it on the replay, put a hashtag replay just so I know that we're all here and you can see what I'm seeing. Hmm. All right, let me just check in and make sure that we are all on board. Sorry for the delay. We're going to give folks just a few more minutes to join us. All right. I wasn't able to see the comments before, but now I can see them. So lovely to see you all. So excited that you are here today, and thank you for joining. We will go ahead and then get started, and I'll be able to answer questions throughout as well. So, as I shared before, my name is Miss Jai. I have a master's in public health, and I provide capacity building training and technical assistance for gender affirming care and inclusion. Additionally, I am a health and wellness educator, and I've worked for the past decade in health behavior and health promotion, developing and implementing prevention and care programs, and working with trans individuals and groups to maximize our health potential. My pronouns are she, her, and he, him, and I'm currently living in occupied Akimel O'odham and Payapash land, or Phoenix, Arizona. I would love to hear from those that are watching today's training. If you can share in the comments your name, pronouns, and where you're tuning in from today. Awesome. So, Xander, you're tuning in from Denver. Welcome. Sasha from Peterson Clinic. Hello. In Tucson. Sarah from Tucson as well. Thank you all so much for joining us today. It looks like there might be a little bit of delay in the comments. So as we're going through and asking questions, if I miss your question, we'll have the opportunity to discuss those at the end of the presentation as well. Thank you all so much for being here. And I have another question for you. If you had to rank on a scale of 1 to 10, with 1 being very little and 10 being a lot, how would you rank your knowledge about providing services to trans and non binary people and communities? You can go ahead and put that in the chat as well. All right, so I'm seeing some fives. I'm seeing a 6.5, a 7.5. Wonderful. Hi, Lauren. Thank you for joining. Hi, Dilip. I hope I'm pronouncing that right. Thank you for joining as well. Like a 4 out of 10? Okay. So, thank you all for responding to those. So it seems like we have a mix of folks who have a lot of knowledge, and some folks who are going to be learning a lot today. I appreciate the fact that we all recognize that we have places to grow and more for us to learn. That's really great self-reflection for us. And I commend you all on being here to spearhead that growing and that learning. Ask Miss Jai got started out of a necessity to provide additional training and education opportunities for health providers on supporting trans and non-binary people. We know that trans and non-binary people face a number of barriers in accessing health services in our country. And for those who are engaged in services, experiences of discrimination or fear of discrimination can quickly push us out of care. In my work as a health educator and public health specialist, I find that providers care very much about the patients and clients they are serving and take the care that they are providing very seriously. But they do not always know how the health environment can be set up in a way that restricts access to care for trans and non-binary people. This training is designed to help give some tangible items that can be implemented within your health environment. With these tips, it is my hope that health spaces will become a bit more inclusive and welcoming to trans and non binary patients and clients, and overall improve the health outcomes of trans and non binary people. So, here's a bit of what we're going to be learning throughout our time today. Our 5 tips will take us through discussing some of the terminology and language pieces for creating gender affirming health environments, including using gender affirming and gender neutral language, and how to update our forms, documents, and data collection processes. We will then look at how we can avoid gendering services, and if we already have services we provide for specific genders, how we can potentially expand those or make them more inclusive for trans and non binary people. We will then move through a conversation meant to identify and check some of our own assumptions before discussing how and when we can engage the community in developing our health environments to be inclusive and culturally responsive to our needs. Finally, we will wrap up with an opportunity for questions and some opportunities for additional learning about how to support trans and non binary patients and clients in your health environment. Please feel free to put questions in the chat as we are going through the tips today. After each tip, we will have a chance to talk through some of these questions. So if you put them in while we're talking, we'll have some opportunities. So if you're ready to get started and learn these tips, go ahead and put "I'm ready" in the chat. And I see some more folks have joined us, so thank you so much for being here and welcome. All right, I'm seeing we are ready. So let's get started with the first tip, which is using gender affirming and gender neutral language. There are a couple of terms we need to define to discuss gender affirming and neutral language. Now, it is important to note that terminology and identity language is constantly shifting, and the way that we select and ascribe identity language to our bodies can be incredibly personal and different from person to person. So, though these are some overarching ways of describing our identities, individuals may use different language to describe themselves. The first term we are going to define is gender identity, which is the way that someone internally feels about their gender and the language they use to describe that identity. The second term is gender expression, which is how we present our gender externally to the world. The third term is gender assigned at birth, which is also sometimes called sex assigned at birth. This is the gender that is assigned to an infant after being born based on an inspection of external genitalia. The fourth term is legal gender marker, which is the current gender marker that is on legal documentation, such as identification and insurance cards. And then the fifth term is pronouns, which is the language that we use to refer to someone in the third person with respect to their gender identity. So some examples of each of these are for gender identity. The language may include agender, cisgender man or cisgender woman, non-binary, transgender man or transgender woman, and two-spirit. As a note, two-spirit is an umbrella term used by some indigenous communities in North America to describe trans people or third gender people within their community. Examples of how we may express our gender are through dress, mannerisms, and the social gender roles that we may take in our communities. Examples of language for gender assigned at birth may be AFAB or assigned female at birth, AMAB or assigned male at birth, or intersex. Examples of language for, or depending on where you live, legal gender markers may only be an F or an M. However, in some countries and in some states, there is a third, some states in the United States, there's a third gender marker now, X, which is available. And then examples for of language for pronouns may include he, him, his, or L, she, her, hers, or ea, they, them, theirs, or L, and sie, zim, zir. As I mentioned before, language is constantly shifting, so we can find that there are other words or terms that our patients or clients use to describe themselves. If we hear an identity we haven't heard before, it is appropriate to ask the individual what that identity means to them. In our society, if someone is born and labeled a specific gender at birth, the assumption that is made is that their gender identity and their expression will match that gender at birth. This is what we would term a cisgender identity. And we would use the language cisgender man or cisgender woman when describing someone with this identity. However, we know that there are lots of folks whose gender identity and or expression does not match their gender assigned at birth. When someone's gender identity and or expression do not match their gender assigned at birth, they are transgender. They may still identify with a gender binary of male and female, and therefore identify as transgender men or transgender women. When someone's gender identity and or expression do not fit within a male-female binary, they are non-binary. And when someone does not feel internally like they have a gender identity or that they have a gender expression, then they would be agender. When we talk about sex or gender at birth and current identity, it is also important to keep in mind that while some transgender people see their sex and gender as separate things, other transgender people may not see them as separate, regardless of an interest or ability to have surgical affirmation. Still, other folks don't like to describe themselves as transgender and may instead describe their identity. So, for example, saying, I identify as a woman, or describing their experience. So, for example, I am a woman who was assigned male at birth. So, why is this important for us as providers to understand? First, it is important to know that gender expression may not always reflect a person's gender identity. Not everyone feels safe expressing their gender, and therefore we can't assume someone's identity strictly by how we perceive them. Secondly, this is important because the way that we talk about health services can sometimes reflect gendered language that can be off putting or create distress for folks who experience dysphoria with those parts of their body. So, I've just gone over a lot of terminology and language. What questions do folks have about the language so far? Feel free to put your questions in the comments. And if there are no questions, you can just put the number 1 so I know that we're all good and we're ready to move on. Okay, I'm seeing some ones come through. Awesome. So now we're going to talk about how we can shift to gender affirming and gender neutral language in our services. In a health setting, using gender affirming language addresses the first concern, which is that gender expression does not always match gender identity. We are affirming by using language that reflects the identity of the patient or client who is sitting in front of us. The way we learn about this identity is by asking the individual about their identity, their current name, and the pronouns that they use. By asking the person's pronouns, we get a better understanding of how they see themselves in the world and provide space for folks to be respected from the moment they engage in services with us. This also shows transgender and non binary patients and clients that we are trying to create a safe and welcoming environment for folks to show up in authentic ways and be affirmed in that authenticity. After asking pronoun and name, it is important that we use that pronoun and name with the individual, regardless of what name or gender marker is on legal documentation. Sometimes we may default to a gender neutral pronoun, such as they, them, if we are unsure of the person's identity. This is okay when we do not know the person's identity. However, if they have told us that they feel affirmed using feminine pronouns, such as she, her, and hers, then it shows respect for identity if we use those pronouns when speaking about her. To be affirming, it is also necessary that we revise outdated language. This includes language that is not person centered. So, for example, instead of saying female to male or FTM, we will use current person centered language that prioritizes the identity of the individual. such as trans man or transgender man. Depending on the situation, we may also need to document the gender the individual was assigned at birth and may say AFAB or assigned female at birth individual. Similarly, we no longer say male to female or MTF and instead move to person centered language such as trans woman, transgender woman, or if needed, AMAB or assigned male at birth. It is also important to note that someone who is transgender is never referred to as a transgendered. Transgender is an adjective and should come before the gender identity of the person. Additionally, for those of us that work in infectious disease and discuss risk language terminology frequently, we see that some of that language is also unclear as to whether transgender people are included or excluded. For example, MSM, or men who have sex with men, is used pretty frequently, but it requires clarification as to whether this includes transgender men who have sex with cisgender men and or cisgender men who have sex with transgender men. Because gender has become part of the equation for this risk category, it is necessary that we clarify what is meant so that we are collecting information correctly and not unintentionally erasing transgender people. To address the second concern, which is using gendered language that can be off putting or can create distress for folks who experience dysphoria with those parts of their body, we can move toward more gender neutral language in assessments and services. So I want to put this to the group. What are some things we could say instead of brother or sister, father or mother, son or daughter, boyfriend or girlfriend, or husband or wife? Any of those categories, what could you say that was not a gendered language for one of those? Go ahead and put your response in the comments. All right, so I'm seeing sibling, partner, parent. I'm seeing spouse, sibling, partner, child. Yeah, these are all great examples. Guardian, that's a great example as well. Thank you for those. What about some language that we could use instead of general language, like, hey guys? What could we say instead to get someone's attention or address a group? Go ahead and put your response in the comments. All right, so I'm seeing friends. Xander, I'm the same. Y'all is my preferred gender neutral term for that situation as well. Itza, I'm seeing hello everyone, y'all. These are great examples as well. So thank you everyone for those suggestions. This is gendered language that we may use in everyday life or in trying to get more general information from a patient or client, such as a health history. We also see that there are very specific procedures that carry a gendered connotation as well. So, for example, we may use language like breast exam or well woman exam. Alternative language that we can use includes chest exam instead of breast exam, and cervical screening and pelvic exam instead of well woman exam. Shifting this language can be helpful in discussing the necessity of the exam with your transgender and non binary patients and clients without alienating them due to the language used. Additionally, it can make it more comfortable for us as providers to bring it up with patients who have these body parts but do not identify as the gender associated with the body part. Now, I want to take a second to pause and see what questions folks have about shifting from gendered language to gender affirming and gender neutral language. So feel free to put your questions in the comments or put a one if you don't have any questions. And I see some folks sharing that sometimes it's challenging to change our language. Absolutely. Thank you for sharing that. And Xander, I appreciate this additional suggestion for a more professional setting, peers, colleagues, esteemed guests. Absolutely. So there's a request for some resources on for up-to-date terminology. There are a couple of potential resources that I can share at the end of our conversation today. I'll also be coming out with a resource list that just shares some basic terminology and then also additional resource lists. One of the challenges we run into is that because language shifts so frequently, we might be able to get some general language like we have here, but it's not always applicable to every situation. So I always encourage folks that for any terminology or language list that you have to still use them with caution and move with information from the patient or client, so that they are the ones that are informing you as to what it is their identity is and what language they use. And then I have another question here. If someone doesn't identify as a transgender man or woman, how would we address that? So there's lots of ways that folks can identify. So they may identify as trans and non-binary. They may identify as non-binary. They may identify as a man or woman and say they don't use the language trans or transgender. So if they're saying I identify as a woman, then you can say this is a woman. If we're trying to document for the purposes of like a medical record, then we might say X patient is a woman of trans experience, or X patient is a woman who was assigned male at birth. So there's a couple of different ways that we can document it. And what I would encourage folks to do is to work with their medical team to come up with concise and consistent language around what that's going to look like so you know what you're going to be looking for each time. And thank you, Emily, for clarifying. Yeah, if they don't identify as what they were assigned at birth, but would prefer to be called man or woman. Thank you. And we'll talk about data collection in a bit as well, which will give some additional ideas on how we can collect that information. Thank you, everyone, for those questions. So use of affirming and neutral language is really foundational to the other tips we'll be discussing today. And it leads us directly into our next tip, which is tip number 2, updating your forms, documents, and how you collect data. We can update our forms in a couple of different ways. First, we can provide space for folks to indicate their current name and pronouns, and if necessary, indicate their legal name. I would suggest only collecting legal name if it is necessary for the services you provide, such as services that require insurance billing or the submission of legal documentation for services. We can also allow for individuals to disclose on forms their gender identity and gender assigned at birth through a 2-step process. First, asking the individual's current gender identity, and then their gender assigned at birth. The 2-step collection process can be helpful for not only how we will navigate health assessments, but it will also help us when we are looking at data collection and accurately reflecting the transgender and non-binary people in our services. This is also a way that we can collect that information when someone's gender identity is not the same as the gender they were assigned at birth. And we can still be respectful of that gender identity. But for the data collection purposes and health assessment purposes, we know that this person is living a trans experience. Beyond demographic information, we can also review our forms and documents to see if there are gendered sections to fill out. So for example, if we have 2 separate health assessments, one designated for men and one for women, then it likely will not meet the needs of transgender and non-binary people. If the assessment is given to the individual based on their current legal gender marker, then there is a high likelihood that we may give an assessment to a trans or non-binary person that makes assumptions about their gender, since only 10% of trans people in the US have all their identity documentation matching their current identity. If we provide the assessment based on how we perceive the individual's gender, then there is also a high likelihood that we will provide the individual with the wrong assessment, resulting in asking health questions about organs and bodily functioning that are not applicable, or missing assessment for other health needs that would be applicable. What we can do instead is consolidate to one health assessment that asks about bodily functioning and which organs the individual has. An organ checklist is a way that we can also provide appropriate health screening for cisgender individuals who have had organs removed. For example, if a cisgender woman has had her uterus removed, then we wouldn't need to ask questions related to risk for pregnancy. We also need to then revise language from gendered language about the body. So, for example, moving from language like the next section is for women only to the next section is for any person with a uterus only. By revising the forms that patients engage with most frequently, we are also ensuring that we are asking information of all patients and clients, and not just those we perceive as being transgender or non binary. As I mentioned before, because gender expression does not always match gender identity, we cannot assume someone is cisgender or transgender based on their appearance alone. So it is necessary for us to standardize asking about identity with every patient or client. Sometimes there is hesitancy or discomfort with asking all patients or clients their gender identity or pronouns. However, several studies have found that the discomfort that providers feel in asking about identity is disproportionate to the discomfort that patients and clients feel in disclosing the information, with providers often feeling greater discomfort asking. This is one of the motivating factors for why collection of gender identity information is a requirement for organizations billing to Medicaid and Medicare. When documenting an electronic medical records, case notes, etc., it is important to use the individual's current name if you are documenting with a name and the current pronoun of the individual. This is good practice for you to prevent misstep or mistake when communicating with the patient or client and ensures that others who review the information understand the pronouns and name the individual uses. It is also necessary for us to use gender neutral language in how we discuss the health needs of the individual. We do this by focusing on the anatomy, conditions, and symptoms the person is experiencing. So, for example, instead of saying patient X is a male to female transgender experiencing urinary discomfort, we may say patient X is a transgender woman with a prostate experiencing urinary discomfort. Documentation sometimes also includes what we may be giving to our patient or client at the end of our visit. If we are giving documents specifically about a health concern, revise those documents to be gender neutral as well. So, for example, instead of documentation that says women may become pregnant if, the documentation could say pregnancy may occur if an individual, etc. There will also be times when we may need to give patients documentation that includes their legal name or gender marker, even if it does not reflect their current name or gender identity. For example, if we are providing patients with lab work or a referral for services that will use insurance. In these instances, it is important to preface why an individual's legal name and gender marker are on the documentation, so as to prepare the individual and let them know you recognize that it is not their current name or gender identity. Now I'm going to take a pause because I see there's a comment. Standardization of forms would be ideal as each health, missed it, as each state slash health system slash municipality has a different process, which can be very confusing and highly biased. I absolutely agree. One of the challenges that we find is in standardizing language is because language shifts, it becomes difficult for us to pin down one standard form. But that's why two-step gender identity collection has become the gold standard for collecting information because it allows us the opportunity to understand how someone was identified at birth based on that external genital check and also their current gender identity. So in data collection, I'll talk a little bit about how that can be standardized even when the information isn't always the same across systems. So many of the ways that we discussed in updating our forms and documentation will directly lead into how we collect data and what we do with that data. So first, shifting to a two-step gender identity collection and including legal gender marker in data collection is the current recommended best practice. Here is an example of how we can collect that information. This includes a list of predetermined language and the option to write in a different identity than one listed above. Because language can be geographically and culturally different and contextually different, it is important to work with your local community and patient or client population to identify the language that is used most frequently. Alternatively, you can have gender identity be a write-in option instead. Secondly, when creating a write-in option, we want to avoid the word other when discussing identities. Instead, using the language different identity, please state, or just a blank write-in option is preferred. This is because as transgender and non-binary people, we have been historically pathologized and othered in health settings, resulting in our humanity being stripped from us. Instead of perpetuating that othering, minor shifting of language can create space for folks to disclose. For data analysis, there can be a lot of concern of going to an open write-in category for gender identity because we have grown accustomed to having finite categories for gender identity or gender markers. However, we can analyze this information and review non-binary data in our systems. Partially, this is through creating larger category buckets for identity to get a better understanding of the populations that we serve. By collecting information about the populations within our health environment that identify as cisgender and those who identify as transgender or non binary, we can accurately speak to how we are serving those populations and communities. It is necessary for us to collect accurate information, not only so we can be sure that health screenings and assessments are going to be accurate and appropriate for patients and clients, but also because often this health data is used to inform our programs. If we are not asking about trans and non binary identity, then we are not able to speak to the trends in program populations, disparities in the health of trans and non binary people compared to cisgender people, and which populations we are actually serving. Instead, what will happen is transgender and non binary populations will be incorrectly categorized in a cisgender male or female population, which can skew the results of that data. We may also find sometimes that there are surveillance or data collection forms that we are unable to change or modify because they belong to another agency or surveillance system. In these situations, we can still ask assessment questions as we would ask on our own forms to get a better understanding of the individual in front of us and inform them that the data collection we have to fill out does not have that same language. An example of this would be collecting demographic information for a funding agency. If that agency's demographic information is not updated, then we may need to select an outdated term like male to female to be sure that we are reflecting that the individual is transgender. Now, I just shared a lot of information. So, what questions do folks have about tip number 2 of updating forms, documentation, and data collection? Please feel free to put those in the comments before we move on. Or if you don't have any questions, if you're like, I'm on board, this makes sense, you can also just put a 1 in the comments as well. So I see a question has come through. How might you navigate a situation where somebody has come out to you, but may be concerned about being outed through documentation? This is a great question. So, the first thing that comes to mind for me is that we should always take the approach of allowing the patient or client to direct how they want to engage with the system. Oftentimes, our autonomy as trans people is taken away from us within health systems. So and you clarified like kids or people with guardians. So let's say I'm working with someone who's under the age of 18 and they've come out to me as trans or questioning their gender or unsure of their gender identity. And then what I might do is I might follow up with questions of what name would you like me to use with you? What gender pronouns would you like me to use with you? Are there any folks you don't want me to use those names or pronouns in front of? Are you comfortable with this being in your file or your form, or would you prefer I only collect your legal information? So it would be great to in an ideal world we would be able to sit down and we would have guardians and parents and family and other folks on board, um, but it can be very challenging sometimes when we're working with folks who are under the age of 18. I worked with a lot of LGBT youth throughout most of my career, and we would have a space for like a current name that the person goes by, and then a name to use if we had to like call their home or we had to speak to a parent or guardian. So that's also a way that we can ex- explore and expand upon that, and also put the autonomy back into the hands of the individual as to how they would like that directed and who they want knowing that information. And then I see a question here. How can a layperson understand which option to choose? I'm not entirely certain what you mean by the question. If you want to expand a little bit on that in the chat, then we can go ahead and answer that a little bit later as well. And Lauren, it would be great to have the buy-in from senior executives for updating data collection forms. Absolutely agree. I think that this is both a top-down and a bottom-up structure in how we're going to change our health systems for sure. Wonderful. Then we'll go ahead and move forward if I collect the right things. So this brings us to tip number 3, avoid gendered or sex segregated services. There are a couple of ways that we can avoid gendering our programs. First, if you are already working in an environment with a gendered clinic or health program, it can be helpful for us to think about the purpose behind the program. Is the purpose of the program to increase cervical cancer screenings? Is the purpose of the program to provide a space for masculine folks to meet and discuss their feelings? Is the purpose of the program to link and maintain patients or clients on HIV medication? Once we have the purpose, then we can begin to look at how trans and non binary people fit into the services or excluded from the service. So, if the purpose is to increase cervical screenings, and we know some men have cervixes, then we know the program needs to appeal not only to cisgender women, but to all people who could use the service. Similarly, if we have a program that is designed for masculine folks to be able to show up and participate, then it should be designed to allow space for folks of all masculine presentations to participate, regardless of the gender the individual was assigned at birth. So now that we know what the purpose of the program is and what we are trying to achieve, we can do a walkthrough from the perspective of the patient or client. This is meant to help us understand how gender exists within our environment and what intentional and unintentional messages these send to our patients and clients. Critically review your waiting room space. Are individuals separated by gender? Look at the decor. Does it favor a specific gender? If it includes representation of individuals, does that also include trans and non binary people? This review should also include review of restrooms and public accommodations. Are there gender neutral restrooms available for patients and clients on all floors? Are they easily accessible and ADA compliant? If we have a program that provides other accommodations, such as shelter services, clothing, or hygiene services, are those gendered? Or are they accessible to folks of all genders? Are our brochures making gendered assumptions about who may be experiencing health conditions or need access to care and services? Reviewing and modifying these spaces can help to create a safer and more inclusive environment for our trans and non binary patients and clients. Part of avoiding gendered spaces is also in how we welcome and greet our patients and clients. Do staff use gendered language such as Mr., Miss, Mrs., Ma'am, or Sir? How are we calling patients back? Do we use their current name or do we use their legal name? Or, as was just brought up in the questions, do we have an alternative name that we can use when we are calling and leaving messages? If our spaces have traditionally provided services for one gender, such as an OBGYN office, are we interacting with patients under the assumption that all patients will identify as cisgender women? Dropping gendered language and assumptions of identity when interacting with patients and clients can help to build rapport with trans and non-binary patients and clients, especially for our new patients. As always, with developing and changing programs for specific populations of people, it is necessary that we receive input and review from the community that we are trying to serve. When making changes to your physical space, it is necessary that we engage trans and non binary community members in that process. This includes revisions to waiting rooms, decor, patient and client meeting rooms, restrooms, brochures, and other accommodations. This review should also happen on a regular basis. So many health environments develop community advisory boards to help inform the changes and have direct feedback from the local community on how services can be improved. A trans and non binary community advisory board can be created for ongoing or as needed support in programmatic changes. So I want to take a moment now and hear from us all. Think about the health environment you work in or an environment you find yourself in frequently. Think about walking through the door into that space. Are there any things that jump out to you as being gendered right away? Feel free to put your response in the comment section. Or if your organization has worked really hard to move away from gendered spaces, what are some changes that have taken place to help support that? All right, so I see already restrooms are a gendered space, absolutely. Especially if we think about if there are any gender neutral restrooms, where those are actually located at. So if they're available in only one building in a multi-building complex or only on one floor in a multi-story building, then the accessibility of those might be very challenging. Brochures, certainly, thank you. Restrooms with different signboards. So as we're moving towards gender neutral restrooms or moving towards gender affirming restrooms, making sure that we're putting up different signboards for sure. Updating our forms to be inclusive in person first. So I'm seeing a mixture of both still gendered spaces or what we're identifying as some gendered things, and then some things that we've done to shift to gender affirming and gender neutral services. So thank you for sharing those. We also may find in some situations where services are exclusive by design. So for example, if we are doing research as part of our health environment, we may have very specific inclusion and exclusion criteria as to who can be part of the clinic or part of the research study. In these instances, it is necessary for us to include in the definition of the research if the exclusion and inclusion criteria include gender, and if they do, specify if the program is for cisgender and transgender people. This is so that we are not unintentionally looking at cisgender identity as the default and transgender identity as the exception or abnormality. For example, saying that a research program is designed for women ages 18 plus would not be enough because it is unclear if that is including cisgender women and transgender women. Instead, we could say a program is designed for cisgender women ages 18 plus. This also helps those who are interested in participating in the research or study to have clear expectations as to whether or not they would be a good candidate for the program. To be clear, there are a lot of reasons why spaces that are developed and designed for specific populations can be powerful and be meaningful in optimizing our health. This is not to say that there is not a space for those to exist. Instead, it is important for us to be clear when designing them as to their purpose, why they are needing to be exclusive, and then be clear and transparent about that in the ways that we talk about the program. So now that we've gotten through tip number 3, what questions do folks have about avoiding gendered services? Please feel free to put them in the comments. I see there was another comment about gendered services, so age appropriate screenings, mammograms, PSA testings. I think sometimes in the way that we talk about those as well. So if we talk about mammograms as like breast exams or breast screenings, then that language can also carry a gendered connotation. Or if we're sending folks to a gendered space, preparing them for that can be super necessary as well. And if there are no additional questions, you can also put a 1 in the chat so I know that we're ready to move to tip number 4. Awesome. So I'm seeing some ones come through. So this brings us to tip number 4, identify and check our own assumptions. This fourth tip is one that will take a lot of personal energy, time, and commitment. And for most of us will be something we will work on for the rest of our lives. And really, maybe this is less don't make assumptions, since we as humans are prone to assuming as a way to fill in information for what we don't have, and more so checking our assumptions and catching them when they come up. As mentioned earlier in the training, we can't assume how someone identifies based on their appearance alone. Physical and emotional safety, fear of being discriminated against, dynamics with friends, family, or other caregivers can affect someone's comfort and expressing their gender in a way that matches their identity. Therefore, we must check our assumptions that someone's expression needs to match their gender identity. We can do this in a few ways. We can make sure to ask every time we see a patient or client for their pronouns and name, regardless of how we perceive them. For patients or clients we have worked with before, we can ask if they are using a new name or pronouns when we meet with them. We can also inquire with every patient through a standardized form that all patients complete when scheduling a visit. We can prepare for how we will ask about pronouns and identity by practicing asking those questions out loud. We can also be prepared to explain what a pronoun is if a patient is unfamiliar with what pronouns mean or what a pronoun is. Part of practicing asking questions includes practicing asking assessment questions in a gender neutral way. As mentioned before, we may not have the ability to change the forms or documents that we are collecting information on. Practicing how we will ask these questions in more affirming ways and being prepared to address that the language does not reflect the reality of our experiences can help us to navigate those conversations quickly and effectively when in front of a patient or client. When working with transgender and non binary people, it is also important to recognize that stereotypes of transgender health needs can shift the way that we engage with our patient or client. The most common health need assumptions are that trans and non binary people need HIV prevention or care and mental health services. Though there are disparities in rates of HIV and mental health diagnoses for trans and non binary people, these are not our only health concerns and should not be the sole focus of our health discussions. Taking a patient or client centered approach to health services and asking about the health goals of the individual will help us to identify what health needs are most pressing for the individual instead of assuming that their health needs are only related to infectious disease or mental health. Similar to stereotyping, trans and non-binary people's health needs, similar to stereotyping trans and non-binary health people's needs, we can also become hyper focused on a person's transness instead of addressing their health need. This can look like asking invasive questions or inappropriate questions about a person's genitals, transition, sexual functioning, etc., out of curiosity and unrelated to the reason for being seen. This is an assumption we make around master status thinking, meaning we assume that the individual sitting before us values their transness above all other identities, and we focus solely on that identity and what we assume is related to that identity. This, however, can get in our way when we are trying to provide services because we are tokenizing the individual by reducing them solely to their trans or non-binary identity. And because we will then miss out on hearing about the health concerns and needs of the patient or client because of our own assumptions about their health needs. We can also work through our assumption around informed consent and what that means for our patients and clients. When we think about informed consent, we may think about making sure patients or clients sign release related to risk for procedures or consenting to care. However, we can expand the idea of informed consent to a broader way of discussing and getting consent. This can include asking a patient or client for permission before starting an assessment. It can look like letting a patient or client know they can stop a procedure or discussion at any time. Or it can look like asking for permission before touching or before trying to shake a patient or client's hand. This also includes providing materials and discussions on options for care in the primary language of the patient or client and at an appropriate reading or understanding level. Even with the best of intentions, the impact of our words or actions can still be harmful to those we are working with. Therefore, it is necessary for us to know how to address when a mistake or misstep happens. We may sometimes use an incorrect pronoun with someone, or may accidentally revert to a legal name instead of the current name of the individual. In these situations, it is important that we address with these four quick steps. And I hope, if anything you learn from today, that you take this with you. One, acknowledge. Two, own. Three, ask. Four, move on. First, we acknowledge that we have misspoke or made a mistake and apologize for that mistake. We do this by stating what we did and acknowledging that it was incorrect. Second, we own the mistake and share how we will correct ourselves to prevent it from happening in the future. Third, we want to ask for permission to continue with what we were working on. It is important during these situations that patients or clients have the autonomy to decide whether to continue or step away after a mistake has been made. Depending on the gravity of the mistake, it may not be appropriate to continue, and stopping the visit or procedure may be more appropriate. Fourth, with permission from the client or patient, we move on from the mistake and back to the health task at hand. Now, it is important that we do not launch into lengthy explanations for why the mistake was made or our own feelings on allyship or the trans or non binary community. Going into a long explanation or making it about our own feelings as providers shifts the focus away from the individual who is potentially experiencing discomfort and distress and creates a social situation where the patient or client is having to absolve us of our mistake. This is not appropriate and can further that discomfort and distress. It is also important that when we own that we have made a mistake, that we do everything we can to actively work on addressing and preventing it from occurring in the future. Misgendering a patient once during a visit and then using the correct pronouns for the rest of the visit shows that we have owned the mistake and are actively working to correct it. Misgendering a patient and then continuing to misgender that patient throughout the visit makes the apology and ownership feel disingenuous. This can erode trust and rapport that has been established or make developing that trust and rapport much more difficult. Now, in the interest of time, I am going to move into the fifth tip, but if there are any questions that you have about tip four of identifying and checking our own assumptions, feel free to put those in the comments and we'll have the opportunity to answer those at the end of the presentation. So for our final tip, tip five is engaging with the community. So creating our presence in the community goes beyond the transaction of providing a service and being paid for that service. The trans and non-binary community is both diverse and small. Word of mouth about an organization can make or break the trust, rapport, and referral from the community. So we have to be present in the trans and non-binary community in order to build and maintain that trust. This starts with outreach. We must be doing outreach to trans and non-binary organizations within our service area. This includes organizations of all types, 501c3, grassroots, and community-based orgs. Not only do we need to do general outreach, but we need to initiate, engage, and sustain these relationships by frequent and intentional communication. If there is an event coming up for the organization, offer to be a part of it. If there are events coming up for our health center, invite the organizations and members to join. This also means we must shift what outreach looks like. Make sure we are bringing something to the space that provides value to the community instead of just trying to drum up business for our organization. Presence in the organizations, however, is not enough. We also need to go to where trans and non-binary people live, work, and play. If we do outreach to bars, are we doing outreach to bars that frequent trans and non-binary clientele? If we are doing street outreach, are we going places where trans and non-binary people are out and about? If we know there are organizations that have a lot of trans and non-binary employees, can we approach the organization about supporting health initiatives in the workplace? It is important that we are showing allyship to trans and non-binary people in the community overall, and not just as a way to beef up our own metrics. When we are doing our outreach, it is also important that we have promotional materials that reflect trans and non-binary people. This includes brochures that discuss trans and non-binary health needs, clinic and organizational information packets that have trans and non-binary people in the packet, and non-discrimination policies that are clearly shared on materials for the community and include gender identity and expression. This also includes bringing these promotional items to non-trans specific outreach environments as well. Showing allyship in environments that are predominantly trans and non-binary is a good first step, but it feels fake when we run into these organizations in other settings and there is a lack of information about trans and non-binary services present. It makes it seem that allyship is subjective to the audience, which can be off-putting and erode trust. As I mentioned earlier, part of building trans and non-binary inclusive clinics and health organizations is through working with the community to revise and improve programs, policies, and procedures. Eliciting feedback should occur on a regular basis and can be done in a variety of ways. We may have a trans and non-binary community advisory board. We may use participant satisfaction surveys. We may use randomized phone calls or mailed feedback forms. Once we receive that feedback, we should use it to inform and improve our programs and services. Now, sometimes the feedback may be about specific individuals and not the program. When this occurs, it can be difficult or uncomfortable to address the feedback. Knowing this, we can prepare ahead for how that feedback is handled and the procedure for reporting that feedback. We all are trying to do our best within the context of the environment we are working. So approaching feedback as collaborative and agreeing on a procedure internally before receiving critical feedback can be helpful to reduce anxiety and defensiveness when feedback is received. We should also be vetting our referrals before providing them to trans and non-binary people. If we are referring to an outside agency, are we aware of their policy on serving trans and non-binary people? For example, if we refer to a shelter space that separates based on gender at birth, or does not support trans and non-binary people, we will not only be unintentionally harming the individual by sending them there, but we will also be damaging our rapport with them in trusting the referrals that we provide. In some instances, there may be limited resources available, and those resources are unfriendly. In those situations, it is still necessary for us to know what safety and inclusion may look like with the referral and provide it in a transparent way. This will give the individual the autonomy to make a choice about engaging with the service or not engaging. As our presence in the community grows and we are consistent in that presence, we will be identified as an affirming organization. This will bring trans and non binary employees to our organizations. Hiring the community that is being served is a powerful and effective way of investing in our community and also reinforcing the building of affirming and inclusive health environments. However, it is also important to acknowledge and build in structure to support the appropriate training and coaching of staff. Because trans and non binary people experience discrimination in the workplace, including being denied promotions, being fired from positions, and being underpaid, the amount of professional development that happens for trans and non binary people is lower compared to cisgender peers. It is necessary then, when supervising, hiring, and working with trans and non binary peers, to include professional development and support as part of the position. This is not true across the board, and you will also work with trans and non binary people who have had substantial professional development. And so it can be helpful to take an employee led approach to professional development, including engaging their professional goals and interests and providing mentorship to achieve those goals. It is also necessary that we are aware of and provide some of the national resources that can address basic needs. This includes funding resources for transition related care, such as microgrants for hormone therapy, surgical affirmation, and gender affirming clothing, as well as general trans led support, such as the Trans Lifeline, which focuses on supporting trans people who are experiencing mental health crisis or are just needing some additional support around their identities. Finally, presence in the community means investing in our overall health and wellness beyond what the organization can receive from our community. When health relationships feel too transactional, we can feel dehumanized and that our health needs are being ignored. These suggestions can help build a foundation for engaging the trans and non binary community beyond what we, as any one organization, have the scope and resources to offer, which reinforces then our commitment to collaboratively improving the health and wellness of trans and non-binary people. Now, before we move into some final Q&A, I would like to share a special announcement from Ask Miss Jai. So if you're hearing about these tips, or if hearing about these tips has started firing you up and you are ready to make some changes in your organization or clinic, then I have good news for you. Everyone who is registered for today's workshop will get exclusive early access to my new 8-week course, How to Use the Health System to Support Trans and Non-binary Patients. This online course is designed to support health providers of all disciplines in becoming more confident and comfortable with serving and creating programs to serve trans and non-binary patients and clients. This course will provide both foundational and advanced information on gender diverse communities, explore and identify opportunities in your specific organization, and help you develop a plan for collaboratively change making within your health environment. So if you are watching today's training and you thought to yourself, I want to learn more about how to do this in my organization or clinic, then this new course is right for you. There are only 25 spaces available for this course, so don't miss out on your opportunity to enroll now and get access to live weekly content, a live weekly inclusive strategy call, and our private LinkedIn group to connect with other attendees and network across disciplines. You will receive an email after this training inviting you to enroll in the course, but early registration will only be available until Tuesday, October 4th. After that, the course will be opened up to the general public and the price will increase. So look out for more information in your email on how to register. I really hope to see you all there. Also, you'll receive an email asking for feedback on this presentation. I love feedback. As I've mentioned it multiple times, iterative feedback is important so that we are improving our services. So please look out for that. Please complete the survey for feedback so that I can improve my services to you all. So we'll now move on to some additional Q&A. What questions do you have about how we can be present in the community? Or what other questions or comments do folks have about creating inclusive health environments for trans and non-binary patients? Feel free to put those questions or comments into the chat. Let's see. Can you give one more example of eliciting feedback? Sure. So the examples I gave were we could do a participant feedback or like a satisfaction survey. We could do feedback around sending out mailers or phone calls to patients and eliciting their feedback. We can also uh, provide like a paper feedback form to be filled out in the clinic and submitted anonymously. So there's a lot of ways that we could elicit feedback from our community in order to improve our services. Those are just some of the examples of how we could do that. I do always like a community advisory board. They are kind of labor intensive because you have to have someone on staff generally who's in charge of helping to get folks onto the board and bring items to the board. But they can be the most they can provide you the richest feedback because you're not only getting the bits and pieces of information, but you're also getting qualitative information from the board on specific ways that it can be improved. I'm not seeing any additional questions. So with that, I really want to say thank you so much. Thank you to everyone who tuned in today and for everyone who is watching this on the replay. For more information about supporting trans and non-binary people, please check out www.askmissjai.com and register for our mailing list. Every week, I'm sending out information about resources. I'm sending out information about gratitudes and other organizations that are doing wonderful work in our community. Oh, and I see one more question came through. Does Ask Ms. Jai have any plans to implement an evaluation that can sit as external to clinics that show the public if they are a safe and affirming place? Or does something like that exist? So I am in the process of creating what I'm calling right now a gender scorecard or a gender affirming scorecard, which would be used for organizations to evaluate the services that they are providing, from everything from how the service is being provided to where the service is being provided to the decor to feedback from participants, all of those kinds of pieces. That will be part of the 8-week course. So it won't be released outside of the 8-week course until I receive additional feedback from members of that course. And it will be used in order to actively evaluate what is happening in your health organization or your health setting so that we can then identify the gaps that need to be filled and what needs to take place for that. The goal of that course is ultimately to leave with a plan on how to address gender affirming services within your setting. That's a great question. Thank you so much. Thank you, everyone who tuned in, and I really appreciate it. Please share this broadly and have a wonderful rest of your day.